Nature of a girl, second by birth order, born out of non-consanguineous marriage, right-handed, resident of Malad, hailing from Kolhapur, brought by an infantile mother being reliable, with the chief complaints of frequent falls since 1 month, involuntary movements of the upper limb since 1 month, and slurring of speech since the past 20 days. Child was ordered 1 month back, after which the mother noticed that the child had falls during playing with her peers. This was not associated with any pain or any trauma. The frequency of falls has been increased over the span of 1 month. She was able to get up from bed, was able to squat or roll over in bed. Following this, the mother noticed that she was also dragging her left lower limb while walking. She did not complain of any sensory loss. She was not able to hold her chappals properly. Mother noticed that the child was not able to hold the objects in her left hand and would drop them. She had no difficulty in combing hair with the right hand. She was able to write with her right hand. However, she had difficulty in doing these activities with her left upper limb. Later, the mother noticed that the child has involuntary movements of both upper limbs in the form of irregular random dance-like movements involving the proximal more than the distal muscles and the left more than the right side. These movements increased on exertion and disappeared on rest. Frequency of these movements have increased in the span of 20 to 25 days. The cause starting of speech.
Sir, sorry to disturb you again. Uh, this voice is very hazy. We cannot hear clearly.
No history of fever, rash or joint pain or
Yes,
any
okay.
sort.
Thank you.
No history of emotional liability, no history of altered sensorium or seizures, no history of altered behavior or sleep patterns, no history of any twisting movements, no history of jaundice or abdominal distension, no history of family history of similar complaints, no history of trauma, no history of previous such episodes, or no history of any drug intake. There were no admissions in the past. ANC wise, it was uneventful. It was a registered pregnancy. ANC scans were normal. There were no comorbidities during pregnancy. It was a full-term LSCS because of prolonged labor. 3 kg baby cried immediately after birth, and there was no NICU stay or any history of neonatal jaundice. The child is immunized till date. Developmentally, the child is appropriate for age.
Okay, so what will be your thoughts when a child comes with frequent falls? 8-year-old child, previously normal child, has started falling frequently. What are your thoughts? So to come from broad to narrow. So give a broad thought of why a child would start falling.
Posterior column.
Okay, posterior column. So posterior column, let's take it further. Very good that you started thinking. So posterior column takes care of what? Correct. In sensory, what exactly does it take care of? Proprioception. So we are mainly concerned with proprioception or position sense, right? So now take it further. That when you are walking around and things like that, position sense is important. But when is position sense more important? What is the test for posterior column? Rhombus. In rhombus, what do we do?
Make the subject stand still, feet closed, and we ask the subject to spread the arms in the arms stand, and we ask the subject to close the eyes. And if the subject starts swaying, then the rhombus will.
Excellent. So now in this test, when you close the eyes and when he starts swaying, what does it tell you? What does it mean? What happened when he closed the eyes?
Unconscious perception is being tested here, that the subject is not fully conscious about the surrounding, and that is why his proprioception is not being.
Very good. So you have to put it in other words that when he closes his eyes, he loses the sensation of the ground. Because from his feet he is not getting that sensation because posterior column is affected. But as long as his eyes are open, he can see the ground. So there is no problem. Moment eyes are closed, he loses his sensation. Now he is becoming unstable. So what I am saying is that posterior column may contribute, but it's not the main reason for balance. Okay, because he's able to see the ground when he's walking, right? So he may not fall because of posterior column. Okay, good. Now take it further. Some other reason for frequent falls. Come on.
Motor loss causing the child to fall again. Power loss.
Very good. So power loss. Okay, unilateral or bilateral. Again, making you think. Between the two, which one is more likely? If there's bilateral power loss, he won't walk only, no? How will he fall? Right? So it has to be unilateral more likely. Then there is a disparity which makes him fall. Right? What else? One-sided weakness is what might make him fall. Then something motor system, but not weakness. Think. What is the basis of a hemiplegic gait in RA? Circumduction gait in hemiplegic. Why does a hemiplegic patient circumduct? I'm just leading you to the okay spasticity. So suppose there is increased tone on one side. Okay. Suppose there's increased tone on one side, then that foot will not be able to clear the ground, and therefore the patient may fall. Right? So you said power abnormality, tone abnormality. What else? Come on, reasons for frequent fall. Where else will the foot go down like this? Foot drop happens in peripheral now. So again, one-sided peripheral now, there will be a foot drop, again he'll stumble, he'll fall. What else? Parts of the walking. Cerebellum, very good. So if he's ataxic, he'll fall. Then any other in cochlear, what do you need? What will make him fall? Right. Better word. Balance. If he is not able to maintain his balance, then he'll fall. So something wrong with the vestibular system. Then very good muscle coordination. Then vision. There's a problem with vision and he fall. There are many reasons why this child could start falling frequently. You have to localize from all this. Your negative questioning or direct questioning has to eliminate all this, right? What more do we have in the history? So one important thing which you need to ask is, can it be a seizure? Can somebody fall because of a seizure? What kind of a atonic seizure? That's a very uncommon type of a seizure, but yeah, it is possible. Then something else which you have seen in pediatrics once in a while, something to do with measles, SSP. So what do you get in that? What type of seizures? Myoclonic seizures, or alarm fits. So suddenly they lose their posture, they fall forward, they may fall, right? So one thing that's missing from your history is what would happen immediately after the fall? Whether the child would be able to get up immediately or would take time or would need support or what? That also would be able to help us localize, right? Right. So now that is, then you said, so she was able to get up from bed, able to squat, able to roll over. So all this means what? What are you trying to decide?
Our loss of the group of muscles involved. She was able to get up from bed, roll over and squat. This tells us that the proximal muscles are intact. And she had dragging sensation in her left lower limb, my pocket. And she had difficulty in bearing a chocolate. So this could be something distal causing the fall.
So you're saying that the left lower limb distal part is affected. Either because then there is something to do with the left hand also, right? So how do we interpret that?
So child is having difficulty in holding things in her left hand, blocking them continuously. Some movements in the hand, that's why she
અમારે લેક્ચર છે ઓનલાઈન ચાલુ 5 વાગ્યાથી એટલે
she had no difficulty in combing her hair with the right hand, but left hand she was able to do those things, but there was a movement which was coming in between those activities. So that's why she was not able to.
Okay, so what does that, how will you interpret that? What does it look like?
Looks like an involuntary movement in the use
What kind of involuntary?
choreo,
Chorea.
at this point.
Okay. So you feel that that movement is chorea. Now, you also said right, left lower limb also. There's left lower limb dragging, then left hand she was dropping object, but right hand she was not dropping objects.
Yes. There were involuntary movements of the right hand also, but she was able to do normal hand. So both were affected, but left was more affected than right.
So now the question is, was she dropping objects because of loss of power on the left side, or was it just because of the involuntary movements? What do you think? Any thoughts? Yeah, it could be both. So both simultaneously, or here you feel one or the other is responsible. What we have to try and judge is the power affected or not, because it will change our thinking a lot if the power is affected. We have to decide that.
It is because of the involuntary movements only. But the child's left lower limb is also affected. So it could be a stroke. That's why.
Absolutely. So because she is dragging the left lower limb, that has to mean there is a weakness in the left lower limb. If there is a weakness in the left lower limb, there is likely to be a weakness in the left upper limb as well. So it is not just because of the involuntary movement that she is dropping the objects, right? Okay. And then slurring of speech. So now a little more about that slurring of speech and what do you interpret?
Actually, in this patient, I was not able to
decipher what that slurring of speech really meant. So the child was able to speak, but she had difficulty in formation of those words. That was the only complaint. But those words were meaningful. Mother could understand, but it was not in a normal way that she was talking because she was talking all right.
What I'm asking is, see, we have to differentiate. So can suppose this child has like those involuntary movements, say chorea. So will a coriform child be able to speak normally? Is my question. And when we say typically slurring of speech, we mean cerebellar involved. So what is the difference, if at all, between the two? Will a coriform child be able to speak normally, coherently? Because one of our chorea signs related to the mouth is what?
Looks enough.
Jack in the box tongue. So suddenly the tongue darts, comes out, goes in. So will this child be able to speak normally, coherently, or will this child have slurred speech? What do you think?
Everybody agrees?
Any part of the motor component lost the speech position. I think to that extent, abnormal movements, yes. Tone change, possibly that does not localize to whatever we are trying to say. So far, what we have suggested is there are abnormal movements, there are also some weakness, and there also some problem with balance. So we need to be sure whether one can cause other symptoms or not, or whether the illness has spread to multiple areas that is causing all this. And I think that will be important for us to figure out. We are discussing anatomy at very different places. There is a dragging ears. We suggested posterior column maybe. We are suggesting basal ganglia involvement. There is probably left upper and lower limb, so there's localization. So then I think we are not sure where is the correct anatomy. Is it at multiple places or is it at one place? Therefore, we need to look at each one. Now, for example, take for example the abnormal movements that we are sure of. In abnormal movements was also weakness. How will that come?
So they can cause abnormal movements can cause weakness. And actually, we'll have to see on examination how much the power deficit is there to actually comment on it.
So if you examine a child with chorea, do you get motor system signs? And what signs do you get? Any thoughts? So you get hypotonia, but you don't get loss of power. Power is lost.
So hypotonic child can walk, but he may suddenly sit down, but he can still walk. So the fall coder is abnormal. So we can combine the two with abnormal movements. We can have slurring of speech, yes. So now we are trying to take the help of abnormal movement and try to see whether everything else. So there is some left upper and left lower limb. Will that happen in a situation like Korea?
Or in other words, chorea is always bilateral or unilateral? Very good. Chorea is almost always bilateral. Something is described known as hemipolismus, which used to be seen earlier in EPMs and all. We don't see nowadays.
So we don't know what that left upper and lower limb.
So the only thing is, I thought that because her presenting complaint is the dragging of the limb, etc.,
Abnormal movements have come up
later. So probably there are multiple areas rather than abnormal movement explaining everything.
If you start looking at the story before abnormal movements came in, then we are not talking about any abnormal movement like Korea or what. Then we would have said feature loss of power more than anything. something that started with loss of power, which has gone on further to develop also abnormal movement. Loss of power would mean also possibly the study of speech, but it cannot fit in the abnormal movement. And abnormal movements cannot fit in that gift, maybe resist, and therefore we look at multiple areas of involvement. That must be done.
So we are on multiple anatomical areas. That is our anatomy. Okay. Now pathology. What is it? Is it a acute process, gradual process, chronic process? What? Has it all happened overnight?
Simple. It's not acute, right? What kind of chronic? Is it tumor? Tumor is chronic, slowly growing. What is against tumor in this?
Common sense. Think. All of you are capable of this. They're just teaching you the same thing in an interesting way. That's all. Suppose there's a tumor. What happens? How will the signs come? Okay, so one is raised ICP, but what about the different signs, different anatomical areas getting involved? What would happen in a tumor? Sir is asking.
If it's in the cortex somewhere, what will happen? Tuberculoma, neurocystic surface, seizure, vocal seizure. If it's lower down in the posterior cranial fossa, there are too many cranial nerves, there is likely to be multiple other areas in it. And then raise the ICT or the posterior part rather than the particle. So here tumor is out. Okay. Again, 1 month is a short time, but starting with weakness of left upper and lower limb, or even one lower limb, it could have started with a seizure, not just weak. So that is out. These other pathologies go slowly worsen. There's degeneration worsen slowly. Within degeneration worsening within a month. So now it is not degeneration also. In which other pathology also worsens slowly, but within few weeks, maybe days. Correct.
Demyelination. Very good.
Yeah. So now you got demyelination and multiple areas. Okay.
Now, some things are taken for granted. Do you think this is infection? We don't want that slow 5 decibel. We want 105 decibel. No, no, it can't be infection. Why? Yeah, so there's no fever. Be confident and be strong. Okay.
When sometimes a simple question asked, you are not comfortable. Okay, how can you ask a simple question? You think about something unusual. So this is not infection. Right? So we call it demyelination, not post-infections. That must be. Now the point is, examination at times may show like something different. Why? Because our interpretation of history has not been right. And why is that? Because we haven't clarified from the mother every small point that we are discussing. And after all, mother would say what she has concepted, not necessarily right. So let's leave it at that for a while, and nothing more on this side.
Just for clarification that no history of emotional, so that is obviously a typo. The word is liability. Okay? What does the word mean? Liability to computer becomes smart हो जाता है. But what does the word liability mean? Emotional liability.
Suddenly the child will cry out and he has emotional symptoms like those OCDs.
So labile means not stable. So So lability means not stable. So disproportionate to the situation. And that's a feature of your automatic chorea.
Abnormal is asking whether there's a past history of a viral infection or a vaccine.
No history of
Not start that.
How early that viral infection could be for us to develop this? Could it be a few days before, few weeks before, month before? I'm asking what post-infectious complication occur within short period, long period, very long period.
Yeah, typical example of GPS.
So I take fever 2-3 weeks, right? Many times even earlier within 2-3 days, can it be several months? What happened in recent pandemic? People are coming after months with neurological or myocardial. So today we know that post-infectious complication may occur in 2 days, 2 weeks, or several months. Could such a thing occur after several years? I have measles in my childhood, and several years later, why is that? Very good. So that's not post-infection, really presence of infection, permanent infection. Very good.
Now tell us your provisional diagnosis and then examination.
8-year-old girl, second by birth order with chief complaints of frequent falls, involuntary movements, and slurring of speech, with birth and development being normal and fully immunized, is likely a case of stroke, rheumatic chorea, or any movement disorder. I have put rheumatic chorea because the age, let me clarify. Examination, general.
Just a point to make. When you give a differential diagnosis, few things you have almost put up, like stroke. Can stroke be at different times at different places, but not in the same illness? Moya is one of those, but not in the same illness. It could be last year or something, this month something. So stroke is out. So you may not give all causes of abnormal movements, but therefore we might come to say mostly multiple lesions. If it's multiple lesions, it's not a stroke illness.
The pulse rate was 92 per minute, regular rate rhythm, volume, tension, no radio readal or radio femoral delay. RR was 22 per minute, TP was 96 by 60 millimeters of mercury taken in the right upper limb. Peripheral pulses were well fed, no pallor icterus, clubbing, cyanosis or lymphadenopathy. Head to the child was normal. Anthropometrically, the child was thin. Systemic examination. Central nervous system patient is conscious, alert, oriented to time, place, and person. Cranial nerves, person setting is normal. 3, 4, 6 are also normal. The only cranial nerve affected was the 7th cranial nerve. Wherein, yeah, the 7th cranial nerve in the form of left-sided upper motor neuron palsy. The child had loss of labial fold on one side. However, the upper part was bare, the eyes were open. Tone, tone was decreased only in the left upper limb. Others were normal. So, power, power was affected on the left side, in the shoulder region and the elbow. Elbow and the wrist was 4/5. The rest all was normal. These involuntary movements are sudden, jerky, involuntary, quasi-purposive movements of 4 limbs. All limbs were actually affected. Upper limb was more than the lower limb, and the left was more than the right. There was pronate drift present. Jacking box sign was present. Milk sign was present, and also there was change in the writing of the child. Uh, Reflexes were normal. Sensory system was normal, and cerebral signs were absent. The child 8-year-old second by birth order with complaints of frequent falls and choreoarticulate movements of the left upper limb, more than the right, involving all four limbs with left phenomenon facial palsy without any other cranial nerve involvement or cerebellar or sensory involvement is most likely a case of rheumatic chorea or neurovils. That's what I my definition.
It shows the neurological signs. If you look at my loss of power,
So this shoulder, she was able to lift her arm. This abduction was okay, but she was not able to do it against my resistance.
Correct. So what sir is asking is how do you there is definite loss of power at the shoulder, some reduction in power. So how do you explain it with your diagnosis? Either in rheumatic chorea or in neuro-Wilson's, how do you explain loss of power at the shoulder? And the tone you said in the left upper limb is decreased. And lower limb, left lower limb, tone is normal. Reflexes are also normal. And power is also normal.
And the involved tracking feet is only mild, like between her walks, you could see only smile tracking. Her feet still circumvent. There is nothing obviously. Exactly.
Okay.
when you are not able to explain something which you never expected, the question is make sure whether those signs are. A 4 by 5 is normal. Okay. Adult, you might be able to pick up 4 by 5. In children, it is 4 by 5. Even 3 by 5 is in child. Okay. But in a older child, 3 by 5 should be reasonably required to explain. So that is one. Second is whenever you cannot, do you think it's some past illness that she has forgotten to report to you? And that's the story of a past illness. For example, she has had some poliomyelitis. Okay. And she left behind with a little weakness, which has nothing to do. And she has forgotten long back. Is that a possibility? Because you can't explain with rheumatic polio. First explain is it is really not true weakness. That is number one. It's likely it is not true because the reflexes are normal. Okay. So it's likely not true. There is no upper neuron signs. Nor there is a lower motor neurons because the reflex would have been gone. And to that extent, this needs to be in exam if you find 3 by 5, I would say no, which is normal. I won't say 3 by 5. I would call it normal. Okay. Because 3 by 5 can be expected to be normal. But my question is, could it be an old lesion, lower motor neuron lesion like polio, which she has forgotten long back? My Lord. Earlier days when polio was common and TBM was also common, it was not rare to see a polio child developing TBM after a year or a TBM child developing polio after a year. And you are somewhere lower motor neuron, somewhere upper motor neuron, and you are wondering what's happening. Could it be that? Or you can rule it out. I can rule it out. Now tell me, how can you rule out a lower motor neuron lesion 3 by 5? What other signs you will get besides weakness? It's a previous illness I'm talking about. What happens to a lower motor neuron lesion after months or years?
Muscle atrophy.
There is no muscle atrophy. So this must be a wrong interpretation more than anything. Leave it at that for a while. Okay. But yes, I think when you said left upper and left lower, we are a little concerned. So we discussed multiple areas and we discussed probably even demyelination, etc. Right?
Also, as a rule, remember that only upper limb involvement without lower limb involvement is very rare. And again, you have to explain why. So, from your findings, lower limb is normal and only upper limb, shoulder, and all that. that cannot be a central lesion. Then you have to think whether is it a spinal lesion that also just localized to upper limb. So it's too narrow a localization, right? So whenever you have only upper limb and not lower limb, again be suspicious whether it's really there. Yeah.
And the involuntary movement causes that loss.
So that's what, na? Involuntary movements can be accompanied with hypotonia, but they are not accompanied with real loss of power. But we have to check whether that what appears like loss of power is consistent. So what I mean is, at that moment, if I'm getting a coriform movement or something, I may not be able to do what you are asking me to do. But 5 minutes later, I may be able to do. So that's the way you will have to differentiate, right? Child is coming.
Why do you want to put neurovasculations?
Because
You're right, basal ganglia, but just activate between rheumatic chorea and neurovasculations.
neurological neurosis can present with neurological symptoms.
So neurovasculations is 1 month is a shock. So Wilson can occur without hepatic, obviously hepatic abnormality. But it is gone so fast, which means that it's likely to be immunological. It happens in a shorter time. And I think therefore you're right in putting neurovasculations there. But that is the small difference between them, right?
Also said upper motor neuron facial. Now that is also difficult to
Explain
explain.
about upper facial also. So because you found hemiparesis, we are trying to find the facial also. Just look at the all possibilities.
No, means we'll have to double check the findings, and if the findings are there, then we can't fit in both of these. Rheumatic chorea as well as neurovasculations are difficult to fit in if there is a facial and this weakness. I'll do it.
Yeah, they can see. It was it. Come, all of you come. Was totally observation. Just go on talking.
You have already seen, so now someone else take it. Anybody else can take it. Come, half of you come here.
As usual, sick or not sick, if sick, acutely sick or chronically sick. Okay. Second is growth, nutrition, development apparently. You start from there. Thereafter, you see whatever you think. For example, I see her skull is large. Okay. So go on now saying all that, and then we will see. My diagnosis looking at the skull is a hydrocephalus. So go on first talking. Then we'll bring hydrocephalus in our discussion.
Child is sitting comfortably in a chair.
Hold like this.
Child is sitting comfortably in a chair. Non-sick looking. Moderately nourished. No obvious tone abnormality.
Is she having any abnormal movements? What's wrong?
Some abnormal movements
You can see her
in fingers.
like this. Okay. Whether it's a tics, but in our situation, it's an abnormal movement.
Some abnormal movements can be seen
pelvis and shoulder level and the shoulder level, but bilateral.
So in a neuro case, this proves what was obvious. Then quickly you look for any dysmorphic features or anything quickly. So sir said large head. So you agree with large head, or you want to kind of explain it in a different way?
It is not a large head. It is due to the less nourished.
So how will you put it? Very nice. So the head looks large relative to the body, but I will look at this head size and confirm. So this is the way to answer that I will actually measure the head size.
Frontal boxing.
Not a frontal bossing, it is due to the receding hair.
If you see from lateral side or even now, you can see two blocks here, right? So it's a frontal bossing, rickets, older age, resistant rickets.
Come on, come on. So how will you throw out resistant rickets?
No alopecia.
वो तो ठीक है. Something simpler or more.
No other waist band whitening or lower limb involvement.
Height is okay. So first of all, growth is okay. Okay. Then resistant rickets would mean probably at 8 years would mean a sicker child, not a sick child. So on and so forth. So that is out. Okay. Fine. Then what other CNS can you observe, make out by observation only? So start talking of the cranial nerves. What do you think? Second is normal or not normal? You not tested. Very good. So the child is fixing and focusing, which means vision is normal, which means half the second now you already tested. Very good. Then both six normal or normal.
It is moving eyes in all directions.
Very good. Very good. 7.
Obvious facial deviation.
Tell her to do something. Na? Even without touching, you can do it. What's it?
Facial
Huh?
fold.
What's it? आंख बंद कर जोर से. टाइट, एकदम टाइट. What do you think?
No element now involved.
Yeah, so I also agree that it's symmetrical only. Yeah. Okay, then
Look at the position of the upper limbs, left and right. Why is she putting left upper limb like this?
is it a hemiplegic hand?
It's typical.
Someone show us the hemiplegic hand. करो, दिखा दो instead of speaking. Wrist. Yeah, so flexion at the wrist like this. This is your hemiplegic hand. Correct? Is it that?
It's probably just a hypotonia. And she's just keeping it like this. हाथ सरल कर. And
Okay. Then, so you looked at almost all the cranial nerves. Okay. Now you want to look at power grossly. You'll make her walk. Tell. चप्पल निकाल के. Always make them walk without their footwear. Very good. 40 seconds. Problems? Hold close. Come.
Less off the ground.
Sorry, I can't.
Was less off the
It was less off the ground. Anyone else? Any other?
left up more higher than right.
Exactly. So at times you are lifting her left upper limb a little more to clear the ground, right? So what happens in a peripheral neuropathy or a foot drop type of a situation? Sometimes she was doing, not consistently, and also there were sudden involuntary movements also in the walk.
That's right.
So which is why this is confusing, whether this is really a power issue or it was just an involuntary movement at that.
In fact, while walking, she suddenly jerked. And therefore, it looked like an abnormal pain, but possibly because of the change in bone itself.
You
Check
want
the
to
power
show
that
your
you said 3/5.
check the power. You know, even you check. Whoever, someone else, come.
Just hold the mic for her so that we hear what she's saying.
So, whenever you are asked to demonstrate power, how do you do? Either first of all, when you are doing in the upper limbs, and if it is a bigger child, then you should have enough range available for the movement. Okay? Then you have to show them the normal movement. So, flexion of the at the shoulder is like this, not straight. It is like this. Then this is extension. So first you tell them to do like this, and अभी without resistance. ये हाथ ऐसे कर, अभी मैंने बताया ऐसा. पीछे कर इसको. Very good. So this is normal flexion extension at the shoulder. Now you give resistance as she is doing it. अभी आगे ले. Okay. So then you see whether she is able to do it still, which she is able to. It's fairly okay. पीछे ले. Okay. Now here remember one thing which Udani sir taught us, that you have to let her first start the movement. ऐसे पकड़े अभी बोलेगा आगे ले, so that even you and I can't do. Okay. So you have to first tell her कि just start taking it here, and then you give resistance and see whether she is able to or not. Okay. Then your abduction, ये ऐसे ऐसे कर ऐसे, हाँ very good. ये अंदर कर, अभी कर ऐसे साइड में. And then नीचे अंदर ले. First always do it without resistance and show the normal.
When the mild hemiparesis, you ask them to do this, one arm will go down. So, but that is if you are expecting the
दोनों हाथ ऐसा सीधा रख, सामने ऐसा बस. हाँ ऐसा ही रख. 2 मिनट रख.
Normal movement. Fine.
Solar science. Somewhere. Milk made grape. Oh, yeah, question. First left side power. Actually, see the power is affected a little because when you told her to do left side extension, she's not able to take it properly like this. Her hand is going to come sideways. She's using other muscles. So there is some weakness.
Even here doing, she was using the
Yes. So she's switching to other muscles. So there is a weakness. She's done like this. For flexion and resistance. So see now you should hold here because you don't involve one more joint. So don't let the elbow joint come in. So hold here. There is a definite weakness compared to the right side. Okay, good. Milk made grip. What exactly are you looking for?
The power of spectrum calculation.
So we are not really testing the power. So in milk made grip, what is happening? What are you telling her to do? Correct. And what happens is her squeezing keeps changing. There is squeezing, releasing. So is that because of the power or it is because of the involuntary movements and tone? Right? Power is normal. Suppose power is weak. She will not be able to squeeze at all. Whereas here she is squeezing and releasing. So why is she releasing? Because she is not able, that involuntary movement comes in. Right? Understood? We are not testing power, so don't bring muscle. Just say that I can feel the tightening and relaxing, suggesting that there is a involuntary movement. Right? And what happens in the other myotonia? When you check for the grip, what happens in myotonia? Sustained contraction. So there are many tight पकड़ के then it just almost goes into a spasm. Good. दूसरा कौन सा साइन था? Good. दिखा.
ठीक है करना आता जे पाठीमागे सांगितलं
expect them. The question is, has that been earlier any upper your understanding waist? You feel it behind mild power difference. But obviously there is no such history. Is the head circumference all right? Why should you take head circumference in an 8-year old? And then because you have taken also, I will object. Now defend that. You would say only because it was looking large at it. But the hydrocephalus at 8 years will not have large level measurement. It's hydrocephalus. But if not measured more than normal, there would be not much difference. Okay, it's not a lion. Well, by then she could have vomiting, etc. His IC. Other than this looks large, but may not be. Good. Thank you.
Thank you. Only because this type of a case you were lucky to see. Look at all the signs, elicit them yourself, you'll remember them for a long time, right? Okay. Good. Now, the summary, investigations.
He got admitted. So he got an MRI done today. Provision is normal. ASO titers are also normal. She asked me also. Okay. Thank you.
How are you going to prove both your DDs?
We got a 2D call for them. Normal. 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 Yes, like, yes, any patient worker. MRI is normal.
You say rheumatic.
Rules out Wilson's also.
Yes, but Wilson's is ruled out even otherwise. You don't need an MRI for that. But yes, but MRI is not going to show rheumatic because structural changes are not the functional.
And so the other two statements that ECG normal doesn't mean no rheumatic chorea. 2D echo normal doesn't mean no rheumatic chorea. Means rheumatic chorea is one thing which can occur in isolation with a normal heart. But you don't have to have a heart lesion in addition. Right?
Rheumatic heart could be a permanent damage, right? Rheumatic chorea is no, but it comes under control with some drugs. But heart damage is persistent. You might need a valvoplasty. I think the prognosis is good.
So is rheumatic chorea long-standing disability or how is it? No long-standing.
So there will be no damage. Occasionally it can recur, but that's also not common. So the prognosis is good.
You started any haloperidol or anything? They are still waiting for a diagnosis. Yesterday only she got admitted.
MRI has done pretty good.
Chalo, good. Good case, good presentation, good discussion. Second case we have.
So, first by Batura, born of third degree unsanguineous scarlet, resident of Dharavi, Pathangai community, brought by mother, and informed by mother, came with complaints of fever for 3 days, 5 days ago, yellowish discoloration of face and body, noticed by mother since 4 days, abdominal pain since 3 days, and vomiting since 3 days. A child started developing fever and documented low grade, intermittent, not associated with chills and rigor, not associated with rash, relieved on medication. Child was active during interfebrile period. Yellowish discoloration. Mother noticed yellowish discoloration of face, eyes, and body, initially on the face and then progressed all over the body. 4 to 5 days back, gradually progressive. Associated with abdominal pain, acute onset, dull aching in the right, more in the right hypochondrial region, non-radiating and non-associated with any other aggravating or relieving factor. Uh, and associated abdominal distension, vomiting 2 to 3 episodes, non-projectile containing food particles, small in quantity, not associated with blood and mucus. She had a history of easy fatigability, history of decreased activity, history of high colored urine uh, during this period, and history of one previous PRC transfusion in the past. The mother didn't have any documents, but she told it was because of failure and yellowish discoloration. And also family history of multiple PRC transfusions in family. There is no history of any recurrent infections, no history of any rash or joint pain, no history of bleed from prick site or petechiae, no history of weight loss, no other history of bleeding manifestation, history of breathlessness or fetal edema, or chest pain, no history of decreased urine output, no history of travel or drug history. History of blood transfusion in mother, she had received 3 blood transfusion twice during pregnancy, during abortions, and one post delivery. Uh, the child had history of blood transfusion at 2 years of age. She was admitted for jaundice and anemia as per the mother with abdominal discomfort. She received one PRC, diagnosis was not known, no documents are available. 2 more admissions for fever, AFI at 6 months and 5 years of age. And 5 years she had dengue uh, without any transaminases. The liver profile was normal. Mother is RH negative, not received any ITB during pregnancy. Yes, history of mother, she had history of 2 abortions at 5 months and 6 months of gestation. Both were male fetuses. History of blood transfusion 3 times, twice during abortion and once post delivery. Birth history, full term vaginal delivery, baby cried immediately afterwards. Birth weight was 1.8 kg and breast history was immunization history and developmental histories are normal. Family history, first child is 5 years, 8 months old, well bright. Second two, then 2 abortions at 5 months and 6 months of age. And the second child is 1 year old. 5 year summary, 5 year old.
So what do you make out of the presenting complaints? What does it look like?
From liver disorder.
Yes, so what kind of a liver disorder? Look at the whole story. We have a story of about 5, 6 days with fever, followed by yellow discoloration, followed by abdominal pain, vomiting.
Infection. And acute infection. Probably affected.
Hepatitis. Okay. Now, would you think this is the usual viral hepatitis, or there are some 2, 3 things which are little different, which are different in viral hepatitis? That's how you start things. You will find it the normal Hep A viral hepatitis.
Of high color urine.
It is there, no, in viral hepatitis, it's there.
That's
That is later. What we are learning is that when the patient has come to you just now on 6th or 7th day, he or she is giving this history. Should something make your antenna up to something, you want to ask something in detail.
Prior.
Very good. So one is that the whole illness of viral hepatitis starts with what? And also starts with what happens nausea, nausea vomiting. Anyone of you had a viral hepatitis? No, lucky. You see, nausea vomiting syndrome is very, very important and classical of virus. Of course, your history has to be that accurate, but that is where you start wondering that this looks like hepatitis, yes, virally, maybe some other.
I think if you look at the hepatitis-like presentation, infection is one, autoimmune is another, and metabolic is third. You have written one of them. Viral is not that. It was one of B, C. Is that a possibility? Beyond that, could it be malarial hepatitis? Could it be typhoid hepatitis? Could it be leptospiral hepatitis? All are infection related, if not infection itself. How do you rule out infection? To answer fever, infection. Okay. Viral is not that, because nausea, vomiting, but what about other?
Question is, can it be malaria, typhoid, answer? Think an answer. Anybody?
Treatable conditions. Right. So the thing is that today we know that fever in malaria may be any. You are right. The first statement, fever is high, away dry, but to whom but never had malaria, first exposure, yes. But in some epidemiology where exposures are plenty, malaria has been reported even without fever. Forget about violence coming and biting. I don't even have. I'm right on that. But point is, malaria first, and before is down the line complete. Same is typhoid. Same is lactose. The beginning is not jaundice. Subsequent progress is they're all out. DMC, almost DMC in pediatric practice is rarely chronic. It is known, but for all practical purposes, chronic. So we have not considered.
Liver abscess. And one very important point.
Liver has done this. Why is that?
Come on, now you all also speak. Everyone speaks so that you feel involved.
Liver abscess does not have jaundice, even if it's a large liver abscess. In simple viral transmission.
Think. What is the difference between liver abscess and viral? You need to. Very good. Very good.
Need 80-85% of hepatocytes to be damaged. A large abscess in one lobe has kept many other hepatocytes functioning. Therefore, goes on. Okay? Good. AMV also has hepatitis. It could be commonly acquired. But again, all infection-induced hepatitis complicating Some jaundice a little later to begin with, except viral, but they are primary hepatotropic. The others are extrahepatic viral disorders spreading to the liver. They come after. So the infection is down. That's with autoimmune and metabolic. Now, there is some weakness,
Or
tiredness.
easy fatigability.
So what does that mean?
And one blood transfusion in the past.
So anyway, right? So it's what? Autoimmune hemolytic anemia. Right? And what's the urine like? Is it direct or indirect?
This time you said high colored urine. But in autoimmune hemolytic anemia, do you get high color? In any hemolytic anemia?
So
No.
it's not
High colored viral infection could be causing viral hepatitis. Or it can be misinterpreted by the mother also. And the hemoglobin should be
You're bringing in so many things. So viral infection, we just discussed. Which viral infection? We said viral is so unlikely. And if you're saying hemoglobinuria, that means it is what kind of hemolysis? When? Intravascular. When do you get intravascular hemolysis? 2, 3 examples. VNH, then malaria, like falciparum malaria. Then G6PD with a wrong drug. All these are intravascular hemolysis. So what happens in intravascular hemolysis? The story, will the urine be high colored or will the urine be cola colored, red, cola colored, whatever, right?
acute immune hepatitis autoimmune does not have that. And an acute hemolytic anemia does not have the direct delivery. So then what is this pallor like? Thalassemia. Repeated transfusion dependent hemolytic anemia.
So can this be thalassemia, transfusion dependent?
So there is only one hemolytic anemia which is transfusion.
Chalo, come on. So not transfusion dependent is out. Okay. Can it be beta plus thalassemia?
Or maybe thalassemia minor.
The first answer, thalassemia minor. Can it be thalassemia minor?
What is thalassemia minor? Minor manifestations in thalassemia major. Right?
Yes or no? No. So what is thalassemia minor? Very good. Or is just pulling your leg. What is thalassemia minor? It never requires transfusion.
Diagnosed in pregnancy for the first time. In the first pregnancy, normal hemoglobin is 1. And you find it's only 10. All that. So congenital hereditary anemias are out. Then what? Mother is also requiring transfusion. The child is also requiring transfusion. Hemorrhage? 2 male fetuses died. Must be hemophilics.
Has this child lost blood and that's why this child is getting transfused? Huh?
It could be concealed hemorrhage.
This child. Okay, but so when you are asked, okay, can it be hemorrhage, what will be your thought process? You need a chota hemorrhage for getting a blood transfusion or big hemorrhage?
So obvious history of losing lot of blood. But what about concealed large hemorrhage? Concealed. There is no hematemesis, there is no hematuria, there is no bleeding after trauma. So it's concealed bleeding.
Where can it get concealed? Which part of the body lot of blood can accumulate without any symptoms?
No such thing. If it happens abdomen, severe pain. If it's brain, you are gone. So no concealed bleeding. So it's not hemorrhaging. So it is anemia, all right, not congenital. Okay. Could it be then acquired? So again, back to autoimmune. But autoimmune hemolytic anemia does not have direct bilirubin. So now how do you sort out this problem from somehow?
Any thoughts?
Must be Wilson's. Wilson's have hepatitis and also some 5% of Wilson's have anemia as well. I got the diagnosis. It must be Wilson's. What's your point against this?
Come on, come on. 5-year-old presenting complaints. AF ring will see on examination. What else?
And 5 years is a typical age for
No
Wilson.
basal ganglia.
वो भी बाद में आएगा.
5 years is possible Wilson. Yeah. Even occasionally 3 years. But yes, 5 and above Wilson. Big two are above. So this must be Wilson. Presenting with anemia. Mother also possible there is Wilson. We don't know.
Second.
Very good. One is it doesn't present with anemia. Second, how do you fit in the previous blood transfusion? Therefore, that is not.
So this is a hematological question. But we cannot explain jaundice which is direct. So can both occur together? Wilson is one, but get it out. In other conditions, you will have acquired hemolysis, also causing by another way a hepatitis. Not the same disease. Sometimes when two funny things come together, one could be because of disease, another could be because of treatment. And we will not know. We will find out the same disease doing it, but sometimes the treatment doing it. But here the treatment for anemia has been transfusion, and that was one. And transfusion caused direct bilirubin, not injury.
Complications of transfusion, long term.
What all infections you can transmit from transfusions?
Come on. Which infections can you get from a blood transfusion in the past? Hepatitis B, C, then HIV,
Malaria.
malaria.
Okay. Keep all that in mind. Otherwise,
Uh, what about the others? The abortions. How do you think about that? Any thoughts on the mother's history of one child and 2 abortions, then she needing blood transfusions, and she being negative and she's not taken NTD? She's not taken NTD ever. So this 4th conception के पहले she took.
Second and third she did not put she took.
Correct. Second and third she did not take. And so did not take, या nobody gave, या whatever. And those 2 were the abortions. So your thoughts on that? What could have happened? Eye drops. It could have been eye drops. You never know, right? It is absolutely wrong that she didn't receive NTD. We don't know why.
I asked the mother, but the child normally said no, doctor also did not.
Fine, but for you it looks so circumstantial, no? That she didn't took NTD and both of them got aborted. Looks very circumstantial. Acha, sir. So hereditary spherocytosis. Can it be hereditary spherocytosis? Not necessary. It can come at any age. But what are the points for? What are the points against? Why high colored urine in hereditary spherocytosis? Then it's a hemolytic anemia, no? So no high colored urine. So high colored urine has to be a hepatic parenchymal involved. So some hepatitis just now, whether infective, whether metabolic like Wilson's, whatever, all that we discussed. Chronic hepatitis B infection, something like that. Or then, like you said, that high colored urine only is wrong. The history only is wrong. Okay?
Someone. 5-year-old female child caused by water, born of third-degree consanguineous marriage, with still fever, yellowish discoloration of face and body, with easy fatigability, high colored urine, history of previous PRC transfusion and PCQ infection in a completely immunized and developmentally normal child. Probably a case of hemolytic anemia. Maybe autoimmune hemolytic anemia or can be viral hepatitis because of the high colored urine.
So in exam, you should say what when we say viral hepatitis, we talk of hepatotropic viruses. What does that mean? What is hepatotropic virus and what is non-hepatotropic virus? Beautiful. So what are they? Excellent. Hepatitis A, E, all that. And what are non-hepatotropic viruses? Give examples, one or very good. CMV, EB virus. You know, many of those will have involvement of the liver to a small extent. Secondary hepatitis. As part of 10 organs, one organ is liver. Right? So that is non-hepatotropic. So you say that this is viral hepatitis. If at all it is, then unlikely to be hepatotropic virus.
Not to hemolytic anemia, no, because you have high colored urine. So both need not be considered. We have something else. That's what we have been discussing here. The first transfusion was possibly for severe anemia, not hemolytic, which caused some antibody responses, donors and the recipients, and kept on worsening. Okay. And which other anemias may need a transfusion? Can the deficiency anemia need a transfusion? Means ideally, anybody can give for iron deficiency, but we know iron deficiency almost never needs a transfusion. But any other deficiency anemia needs a transfusion only because it is missed for a long time. And can B12 ever jaundice?
Want anybody? Can B12 deficiency have a mild jaundice?
About 5-10% of children with B12 have a mild jaundice, which is hemolytic jaundice. B12, because the DNA problem in the marrow itself makes the earlier generations of RBCs hemorrhage, and therefore you get mild jaundice. But that's hemolytic jaundice. So I'm trying to say that did the mother have B12? the child has also B12 because diet is involved. They get transfusion because anybody who sees anemic child give iron. B12 is not good. And the B12 continues. And the anemia becomes severe, you get the transfusion. You get better for 6 months, 1 year, you get B12 again. Apparently recurrent. Or then add further, those recurrent transfusions have given one of the viruses, and that causes damage. I think you will have to combine these such unusual situations, but two separate cannot exist, and two together also cannot exist. So we'll have to decide something else, right? Let's see what investigation.
General examination. Children's condition was moderate of the breast. Pulse rate was 162 per minute, regular rate, volume, no radioactivity.
This child is there for me.
Respiratory rate of 38 per minute, saturation 96.1, peripheral pulses were bounding, TRT less than 3 seconds, failure and equals 4 seconds. Local examination, she had left side posterior cervical lymphadenopathy and viral centimeter, non-mobile, non-vector. Vector examination was normal, anthropometrically she was normal. Uh,
One sec. You said 5-year-old, no? So how 12 kg is normal at 5 years? 12 kg is not minus.
मॅप येत आहेत आपल्याला
मॅप येत आहेत आपल्याला.
Something is wrong somewhere. Huh? So
Even 93 is still.
Yeah. 93, 94 centimeters is perfect for 3 years. As Palniraman has said, maybe it is 17 kg that you have written as 12. But if it is 12, then it is not -2 to -1. So check on that. Okay?
Systemic examination per abdo inspection, globular shape symmetrical, umbilical center, no scars, sinuses or any, no visible pulsations or peristalsis. Palpation liver was 4 centimeter palpable below the right subcostal margin, firm in consistency, smooth borders and tender. Spleen was 2 centimeter, firm in consistency. Percussion liver span was 7 centimeter. The other systemic examination was normal.
Go back. Findings. What do you make out of these findings? Hold it.
Child has hepatosplenomegaly.
Yes, but now interpret the hepatospleen.
Liver stone.
So what does tender liver tell you? More than infection, you say it's hepatitis. Okay. Having said that, what did your general examination tell? She was very pale, pounding pulses, you said, 162 heart rate. Okay. Peripheral pulses bounding. So what does this tell you?
Even to this anemia, this bounding pulses and tachycardia, which is failure.
So she has severe anemia and she is in high output cardiac failure situation, right? Okay. So now, could this be right-sided failure and that's why a liver and which is tender? Or is this hepatitis?
First, there will be a right-sided failure.
For which she has to be tachypnic also, she has to have Krebs also in the RS, right? So correlate all these things, like try to correlate what you answer.
Liver span 7 centimeters. So is it normal? 5-year-old.
Enlarged or small?
Enlarged.
Enlarged.
Mildly enlarged. mildly enlarged. That also put me into a little worry. Okay. Acute onset, cardiac failure or hepatitis, the liver should have enlarged a lot. Again, we may check whether it is 7 or 8 or 9 or whatever. The point is, 7 is too close to normal to call it an enlarged liver, but the liver is firm. So suggests that it's some kind already pre-existing. So it's not recent. So the possible liver firmness suggests some chronicity going on. Cardiac failure may be chronic, okay, not acute. Hepatitis is usually acute, but when hepatocytes are swollen, you will get a little firm liver. But span, I thought, was a borderline involved, not large enough to expect. The spleen is certainly abnormal.
And here again, that growth importance comes in. Because if it's a 5-year-old with 93 centimeters, and if that is correct, then she's short. And if she's short and then you are talking of hepatosplenomegaly chronic, and this is a chronic hemolytic, right?
And therefore congenital more. And that's what mother also has maybe. Maybe we could have asked whether mother is also short.
That's why Palniraman was saying spherocytosis earlier.
Diagnosis 5-year-old female child caused by Bertola, born of third-degree consanguineous marriage, with complaints of anemia and jaundice with hepatosplenomegaly, with signs of cardiac failure, with no signs of liver decompensation, with history of previous PRC transfusion, within a completely immunized and developmentally normal child.
Okay, 1 minute before you go on. So I just wanted to re-emphasize that see how so many things can change our thinking. So simple height and weight, if it is not accurate, it can totally mislead us. We depend so much on that to decide whether this child has a chronic problem or a current acute problem. Then whether the liver is really firm or no. We decide chronicity, we decide so many things based on that. Whether the liver is really tender or no. Then the size of the liver. What I'm trying to say is let us try to be as accurate as possible in these small things which can totally mislead us because our interpretation is dependent on it, right?
Paniraman is also asking about whether Dr. Paniraman had put in the chat box whether the mother had subtle icterus. In
No interest ऐसा जेब में से निकाला है कि definitely no interest.
CBC HP initial CBC on admission was 4.133.
Speak louder and because we can't read that.
CBC on admission hemoglobin was 4.1, hematocrit was 12.4, counts were 13,000 and platelet was 628. MCV was 1, MCH 34 and MCH 33. And yes, it was hypochromic, normochromic, normocytic, macrocytic, with anisocytosis. And RBCs tend to 9 to 10 per 100 WBCs. And the count was 14.6, corrected rating 5.5. It was 33.
MCHC.
33.
The RDW of 25.
So what does the indices tell you?
MCV is 105, which is a little higher.
So macrocytic.
Macrocytic.
So which would tell you what? And you plus have microcytic you have hypochromic also, right? Not
Hypochromic also.
microcytic, but you have hypochromic. Peripheral smear shows
Hypochromic, normochromic, and normocytic. with macrocytic.
Microcytic also. So it tells you dimorphic. So what does that tell you? So normally it would tell you dual deficiency, iron and B12. But the problem here is retic count is high. Even corrected retic count is high. So there is definite hemolysis, right?
Because of the recurrent history of PLC transfusion with anemia and jaundice, we thought of an autoimmune disorder and we sent an randomization panel also, which came positive for mixed autoantibodies. DCTS also was positive and the by transfusing PLC, we couldn't cross match the PLC, we did a manual cross match and extended at cross match time.
Okay. So what about the bilirubin?
Bilirubin was normal, 0.6, and diet bilirubin was not. Bilirubin was normal.
So then how come icterus and all that? High colored urine?
Bilirubin.
No. So maybe bilirubin, first of all, bilirubin can't be normal. There has to be some indirect hyperbilirubinemia. But of course, the direct, we already discussed that high colored urine may be misleading us. It could be concentrated urine which they have reported, which reminded me to ask you, have any of you or all of you seen high colored urine of jaundice with your eyes? Can you identify that this is high color? So how yellow is it? How yellow है ना इधर देख के बताओ कौन सा कोई येलो कलर दिख रहा है कितना येलो होता है So it is to the point of orange, that yellow, high colored urine. Okay? It's important to have seen it is that yellow. We call it yellow, but it is almost to the point of orange. That is your high colored urine. So again, ask these questions. When you ask a history and mother says high colored urine, just say kaunsa color, kitna hai? Look at something around you and ask how yellow could it be, right? Yeah, so Palniraman has said that it could be associated B12 or folate deficiency in addition to the hemolytic anemia. So the fact that you couldn't cross-match blood easily, all that totally favors DCT positive, all that favors hemolytic anemia. There's no doubt about that. Autoimmune hemolytic anemia.
I think we only don't know what was the reason of first transfusion before all this happened. As we discussed, it's likely that repeated infections have given further complications. But what was the cause of first? Could it be spirocytosis? MCHC is not, so possibly not spirocytosis. But we need to know what is the initial anemia in a child as well as in the mother that required repeated transfusion and cause further transfusion reactions and therefore possibly that. In a story of high colored urine, but bilirubin being normal, even in indirect bilirubin should have been. So we have some discrepancy, which is not unusual because discrepancies could occur because of our misunderstanding, because laboratory misunderstanding. But science itself has not understood. Okay, so we are not surprised to see this kind of discrimination that really occurred. Only it means that we have to be so conscious about every small little thing and check whether what we feel, what mother says, what laboratory says is exactly what it is. Maybe cross question each one of us can only give it one. Anyway, what has been a possible diagnosis if you are a hematologist?
What have they finally said hematologically?
We can say we don't know. They can't say that.
Yeah, but chronic or acute, because that blood transfusion was in the past.
That this time the child had viral hepatitis, so that pushed the child into the.
Did you have high liver enzymes?
Actually, the protein was also it was not very active.
Correct, but for calling it viral hepatitis inducing the autoimmune hemolysis, that viral hepatitis should be substantiated with a sky high OTPT. Okay. So try to find out all this and tell us next time. And you should also be thinking all this. Don't just accept what anybody says, right? And looking at the whole story, it can't be just a acute autoimmune hemolytic anemia, an episode just now. Because there's so much that has happened in the past, right? Okay.
Next time, tell us what will happen.
Any comments from the online audience? Any questions? Any comments?
It's an interesting case. Thank you. Nothing more. Nothing more. We want the diagnosis next week.
Yeah, thank you. Okay, so thank you everyone, and we meet next Thursday again. Thank you. Thank you for joining.